Let me welcome you to this session on managing children living with HIV. I'm Dr. Chewa Luo, the Global Chief of the HIV program at UNICEF in New York, and my co-chair is Stephen Watiti from Uganda. Before we dive into the presentations, let me first give you some of the logistics. Please type your questions in the chat, and we will have a live session at the end of the presentation. It's now my pleasure to introduce our first speaker. And our first speaker is Dr. Dorothy Mboringacha, and her talk will be on elimination of HIV in children. Dr. Dorothy Mboringacha is a senior HIV advisor on elimination of mother-to-child transmission and pediatric HIV for the UNICEF Global AIDS Program. She's an epidemiologist who's also specialized in pediatrics, infectious disease, and child health. She has extensive experience working in academia, the public sector, and NGOs and international organizations. She currently supports global efforts towards achievement of the global targets to eliminate mother-to-child transmission globally and to attain universal treatment coverage for women, children, and adolescents living with HIV. Dr. Mboringacha is also responsible for fostering interagency collaboration and establishing strategic partnerships within the UN and with other key stakeholders such as ministries of health and civil society. A Kenyan national, Dr. Mboringacha holds a medical degree and a Master's of Medicine in Pediatrics from the University of Nairobi School of Medicine and a Master's in Public Health and Epidemiology from University of Washington in Seattle. Dr. Mboringacha's research area is in the field of PMTCT and pediatric HIV. Welcome, Dorothy.
Greetings, everybody. It's a great pleasure to be back at Interest, and I'm happy to be here in 2021 when it's virtual, discussing a very important topic. Our topic today is the elimination of HIV in children. And in my talk, I'll be focusing on status reports. So where are we? Where have we reached? I'll be identifying specific gaps that we see in our programs and offering potential solutions. So the prevention of HIV in children is one of the greatest successes we have had as an HIV community, starting from the proof of concept study, the 076 study in 1994, that was able to demonstrate that you could avert transmission by up to 2/3. Riding on this success, the scientific community continued to work on making the regimens more feasible to implement in resource-limited settings, while enhancing their efficacy to get the transmission rates much lower than the benchmark 2/3. And then finally, we also worked on simplifying the regimens so that the mothers would find it easy to take the medication, and the healthcare providers would find it easy to deliver the interventions. But the biggest game changer that pushed us to really consider that we could eliminate mother-child transmission was when we moved to the test and treat all pregnant women, the B+ regimen pioneered in Malawi. This was a scalable, feasible regimen that made it possible for healthcare workers to deliver interventions at the lowest level, and that really showed us that there was a path to elimination. Riding on this optimism, the global community set very ambitious targets, with the aim being to eliminate mother-child transmission as a public health threat by 2020. And our goals were to reach and sustain 95% of pregnant women living with HIV on long-life treatment, and also to eliminate new infections annually to less than 20,000 by 2020. In anticipation of success, the WHO set benchmarks for validation, where any country wanting to be validated as having eliminated HIV needed to have a population case rate of new pediatric HIV infections of less than 50 per 100,000 live births. And in addition, they needed to have HIV mother-to-child transmission rates of less than 5% if the population was a breastfeeding population, or less than 2% in non-breastfeeding populations. These were the benchmarks for success that we were looking forward to. But recognizing that high burden countries would take longer to achieve these benchmarks, to achieve validation, a three-tier process was put in place that recognized each step, each victory along the way. The three-tier process recognized increase in coverage, so starting with the bronze at 90%, heading towards gold at a 95% coverage. It also talked to the issue of case rate, starting with a benchmark of bronze at 750 per 100,000 cases, and aiming to go to less than 250,000 per 100,000 for gold. So each step was to be acknowledged, and each step was to be validated, bronze, silver, and gold. And the interventions were, of course, to have been done at scale, at population level. The interventions were to also have been done in a way that was consistent with protecting human rights and ensuring gender equality and the engagement of civil society. These were our benchmarks to encourage countries along the way. So let's reflect on where we are against those benchmarks. We see that by 2020, we have attained a coverage of 85%, which is good, but is inadequate because our benchmark for this year was 95% coverage. In terms of the number of new infections annually, this is where we are falling woefully short. Our benchmark, as you remember, is 20,000 per year. Last year, we were at 140,000 new infant infections, 7 times our benchmark. As you will also note, progress is stagnating. For the past 3 years, coverage rates have remained the same. Something is not working for us, and we need to unpack that. But all is not doom and gloom. If you look at the landscape, we can see that a number of countries, 15 countries and territories have already been validated. So there's still hope that we can actually validate globally. You see here the countries and the years in which they were validated. And we just note one thing of concern, is that of all these countries, none of them are in sub-Saharan Africa, the region most impacted by the epidemic, the region with the highest burden. So yes, we can claim success, but yes, we are really not hitting the mark as far as sub-Saharan Africa. So let's dig deeper. What is actually happening in sub-Saharan Africa? I'm showing here 2 charts, one for Eastern Southern Africa and one for Western Central Africa. The Eastern Central Africa graph in green shows you that the coverage has been pretty high at 95% by 2020. But the mother-to-child transmission rates remain above the threshold of 5% and are actually only at 8% right now. So we need to unpack why transmission rates remain high despite the high coverage. In Western Central Africa, coverage rates are still below 80%, actually very low at 57%. And transmission rates are at 25 times the transmission rates, or 4 times the transmission rate benchmarks for elimination. So again, really distinct differences between the 2 regions, but none of the regions reaching the benchmarks that we want. Now, if you look deeper and try and find out, so which countries, where is most infections happening? We see here that the distribution of HIV new infections in sub-Saharan Africa occur 80% occur in just 9 countries, the 9 countries listed here, with the top 5 countries being Nigeria, Mozambique, South Africa, United Republic of Tanzania, and the Democratic Republic of Congo. So if we're to make a difference, we really need to zero in on these 9 countries and see how to break the transmission rates and how to get the impact that we need in our programs. So how do we do this? What is going to make the difference is in our focus, is in our better understanding at the country level and at the sub-national levels. A tool that has been developed to help us do this is a tool, the Stack Bar Analysis tool, which is spectrum-based, developed by UNAIDS. And it allows us to look at the gaps and the missed opportunities that we see in pregnant women and to track that against the infant infections. So what I'm showing here is the global Stack Bar. On your left is the number of pregnant women living with HIV, and on your right are the child infections. Let's start first with the pregnant women living with HIV. The blue colors indicate where we've had success. These are the mothers who we've been able to reach with the interventions. The dark blue are mothers who started antiretroviral therapy before pregnancy, so excellent. The blue started therapy during pregnancy, early enough for the intervention to work effectively. And the lighter blue started late in therapy. So these are our successfully reached mothers. All other colors above that are missed opportunities. The gray show mothers who came on to treatment but dropped off therapy. So we're not able to retain them on therapy. The yellow are our abject failures. These are mothers who came to us, but we never gave them antiretroviral therapy. And then the orange are the mothers who got newly infected during pregnancy, and the bright red are the mothers that got newly infected during breastfeeding. The infant bar is color-coded in the same way. And you can see that most infant infections are occurring because mother did not receive ART, the bright yellow, followed by the fact that mothers are not being retained in care either during breastfeeding or during pregnancy. And then finally, the issue of incident infections, particularly during the breastfeeding period. These are the areas where we need to zero in. Now, similar analysis can be done at regional. So I'm showing slides, stack bars here for Sub-Saharan Africa, it's the first one on your left, East and Southern Africa is the second one, and West and Central Africa. And we're not going to go really deep, but at a glance, if you look at the bar to your extreme right, the West and Central Africa bar, what jumps at you is the bright yellow. Most women are not getting their ART. So if one game changer is to happen in West and Central Africa, it is test and treat majority of pregnant women to bridge that gap. When you look at East and Central Africa, when you look at East and Southern Africa, it is not as clear. It's a bit more complex, but we see that still there are mothers who are not getting treatment, but incident infections, particularly in the breastfeeding period, is a big issue, as well as dropping off care. So in East and Southern Africa, they need to really focus in on incident infection, retention in care, even as we try to reach those final numbers with the interventions. So let's look at a country stack bar just to show for illustrative purposes that these analyses can go right down to country level and even to subnational level. What I'm showing here is the stack bar for the Democratic Republic of Congo from last year. And again, you can see that the bright yellow, mother not receiving antiretroviral therapy during pregnancy and in breastfeeding, is the main cause of infections in children. So the program managers, the policymakers can actually see where to target the interventions. So as we do these analyses, they're not an end in themselves. We need to ask ourselves a number of questions. What changes do we need to make to our service delivery to ensure better delivery of ART for pregnant women? We need to ask ourselves who is missing and why. Is it the young women? Is it the women who are members of key population groups who are missing and why? And then we also need to ask ourselves, how can we better support mothers to stay in care and on ART during pregnancy and breastfeeding? Why are women dropping off? We have interventions for these things. We know that mentor mother programs work. We know that peer support works. We know that integration of services, HIV services into maternal child health services gives us better outcomes. We also need to ask ourselves, how do we strengthen primary prevention for pregnant women and their partners? We now know that their PrEP interventions, are we rolling them out in our PMTCT programs? We also know that self-testing is an important tool for getting partners in. Are we rolling them out in our programs? So in addition to the stack by analysis, we need to do a lot of qualitative work and use other evidence within the country to better understand how to prioritize the interventions to the gaps that we have identified. So in summary, what I can say is that there's been significant but uneven progress in PMTCT coverage. Unfortunately, we have hit a plateau in all the regions. The coverage is flatlining. The impact of our programs as they are insufficient to reach our global targets, and we need to act urgently to tailor our responses to the gaps we see in access, to tailor our responses to the gaps we see in the quality of programs, to improve the testing with linkage, to improve retention in care, to improve adherence. These are the things we need to be focusing on. We no longer can have one size fits all. We no longer can have cut, paste. Each place will need to have solutions that are context specific, and countries need to do those analytics. We need to use our data very robustly to have these differences. So to enable countries to do this, UNICEF, UNAIDS, and WHO came together and developed what we're calling the Last Mile to MTCT framework. It's a programmatic guidance that goes step by step to work with countries so that they're able to do the analytics using the stack by analysis, and then prioritize the interventions that are context specific for their settings, either at the national, subnational, or even at the facility level, to be able to make a difference. The guidance are available for countries to use, and that we're framing this guideline as our last push towards ending vertical transmission in mothers, ending vertical transmissions for children. This is our last push. This is why we're calling it the last mile. We're not at the last mile, but this approach will get us to the last mile. And so I'd like to end by thanking you all for listening. I'd like to thank my colleagues at UNICEF and my colleagues at WHO for helping me put together this presentation. Thank you very much.
Comprehensive presentation. I now have the pleasure of introducing the next speaker, Dr. Sabrina Bakira Kitaka, whose presentation is on diagnosing and managing treatment failure in children and adolescents. Dr. Sabrina Bakira Kitaka is a senior lecturer at the Department of Pediatrics and Child Health at the College of Health Sciences at Makerere University in Uganda. She completed a medical degree in 1995, as well as a specialist training in pediatrics and child health in July 2012, both at Makerere University. She was a Gilead Fellow and a research scholar at the Infectious Disease Institute from 2003 to 2011, where she undertook a fellowship in pediatric infectious disease and did research on HIV-infected adolescents. She has a PhD from the School of Biomedical Sciences at the University of Antwerp in Belgium. Dr. Kitaka is involved in conducting basic research on various pediatric infectious diseases and offers clinical care to HIV-infected children and adolescents, most of whom were perinatally infected. She directs the Adolescent Health Training Program at the University of Makerere College of Health Sciences and is the founder president of the Society of Adolescent Health in Uganda. Welcome, Dr. Kitaka, and looking forward to your presentation.
I am delighted to be presenting the diagnosis, management, and challenges of antiretroviral therapy failure among children and adolescents in a resource-limited setting. We know that worldwide, there are about 101.8 million adolescents aged 10 to 19 years living with HIV. 85% of them are in sub-Saharan Africa, and 60% of them are girls. In Uganda, where I come from, 1.4 million people are living with HIV and AIDS, and 130,000 are adolescents aged 10 to 19. The majority are perinatally infected. And the current prevalence of HIV among adolescents is 2.8%. According to the Uganda AIDS Control Program, the highest prevalence of HIV is in the urban areas, including the city of Kampala. So Baylor Uganda is a center of excellence. It was started in 1988, and antiretroviral therapy was initiated in 2003. The HIV clinic was started around the same time and has registered over 12,000 adolescents and young people by January this year. There are two groups of HIV positive adolescents who are vertically transmitted and those who are behaviorally transmitted. And as these adolescents mature and have their life expectancy increase, they face various challenges, including building a social and sexual identity, making education and career choices, gaining autonomy from their parents, and also promoting personal adherence to their treatment. The availability of antiretroviral therapy has resulted in increasing numbers of adolescents living with HIV and AIDS. And yet, these come with various challenges of coping with the stress of being HIV positive. There's been a great evolvement of antiretroviral therapy. We know that in Uganda and also in the PIDC, this was introduced in around 2003, 2004. Initially with meager resources, and then currently we have the test and treat approach that looks at initiating both children and adolescents on antiretroviral therapy. Before, adolescents and children took lots of drugs, lots of pills, syrups and tablets, but now we have had optimization of treatment to the extent that a child or an adolescent takes a single pill or very few medications. According to the recent data from Baylor Uganda, the distribution of antiretroviral therapy among children and adolescents includes the majority on first-line treatment, that's about 75%, and then 24% are on second-line treatment, and 34%, about 1%, are on third-line treatment. So the majority are on first-line treatment, a few are on second-line, and a little number is on third-line treatment. For the children and adolescents below the age of 19 years, there's viral load testing done on a 6-monthly basis. But as you can see, the adherence to antiretroviral therapy and subsequently the viral load tests are really low for children between 1 to 4 years, 84% for 5 to 9 years, 86% for 10 to 14 years, and 85% for those between 15 and 19 years, which generally shows that children and adolescents are not achieving 100% viral load or adherence to antiretroviral therapy. The regimens that adolescents are receiving, first line are 71%, second line are 28%, and still the third line are around 1%. Not so different for those below 10 years and those above. For the adolescents and children on antiretroviral therapy, the male-female ratio is almost the same. And if you look at a 12-month viral load cascade, the adherence increases to about 99%. There are various challenges for adolescents living with HIV and AIDS, which also affect their adherence to antiretroviral therapy, including early sexual activity, continued engagement in sexual relations, and also lack of disclosure. So in terms of optimizing care, to promote youth-friendly services, it's important to train the healthcare providers, promote confidentiality and provide consent, but also seriously cater for the socioeconomic issues and empower the youth to live with HIV, because this will improve adherence. In case you forget whatever I have said, when you're treating adolescents living with HIV and AIDS, and this also applies to children, it's important to have a competency donut that includes knowledge and skills improvement, respecting these adolescents and children, having a non-judgmental attitude, respecting individuals for their dignity, and also understanding them as change agents. So in terms of treatment issues, we already mentioned adherence is a challenge, disclosure is a challenge, but also the ongoing risk of transmission is a challenge, and also transition to adult care. We all know now that undetectable equals untransmissible, and it's important to ensure that all adolescents and young people are undetectable so that they do not transmit HIV. There are various challenges of transitioning to care, including financial independence, support to adherence, and others. And it's important for us to appreciate that transitioning to adult care is not necessarily images, but it's important for these adolescents to be comfortable in the presence of adult patients. And when we promote transitioning, it improves the self-concept and sense of competence. It also promotes independent living. Transitioning in HIV is part and parcel of improving adherence. And as adolescents living with HIV grow into adulthood, it's going to be necessary for us to be able to transition them. This is just an example of how we promote transitioning at the Baylor Uganda Clinic. We have a psychosocial support club, young people transitioning to other different psychosocial clubs. We've done various studies on disclosure challenges, and these affect adherence. We know that disclosure is more difficult for girls because it's associated with stigma. And also the SARS-CoV-2, the COVID-19 pandemic, has created its own challenges. And since the beginning of the pandemic, we are seeing less and less of our patients physically, and this is affecting their adherence. Uganda has had its own brunt of the COVID-19 pandemic, and everyone is affected, but those especially living in poor communities are most affected. So there are key issues related to the lockdowns, repeated lockdowns, multiple waves, electronic review of clients, and reduced face-to-face client contact because of infection control and prevention. Obviously, there's various challenges of school returns and also scheduling of patients. And I just want to quickly take us through a case of MN, a 25-year-old individual who was initiated on antiretroviral therapy in 2004. Both her parents are deceased. She was living alone, but was working. And I'll just quickly show you that she started on D40, then transitioned to AZT. In 2009, she was put on TDF-3-TC efavirenz, but her viral load trends were concerning. In October of 2020, her viral load was 1,700, and she had repeated adherence counseling sessions. She was switched to a dolutegravir-containing regimen, and after 3 months, she was undetectable. So our plan is to support her with adherence. This case demonstrates that even though a patient continues to fail, they should continuously be supported and optimized to the best treatment. Case 2 is a 7-month-old baby who I saw about 2 weeks ago. She presented to us as a new diagnosis of HIV. She had pulmonary tuberculosis, severe acute malnutrition, and pediatric HIV. She'd been started on abacavir, 3-TC, lopinavir, and ritonavir. Her mom is in a polygamous relationship and was not able to adhere to her therapy because the mom needed to put her treatment in a fridge, and she also said the medication was bitter. Fortunately, we've now had DTG 10 milligrams, squad tablets, and even the pellets. And now baby has been switched to dolutegravir. And this has improved her adherence to treatment. And the follow-up of the TB and malnutrition units is much better. These are our national guidelines, including the 2nd and 3rd line treatment guidelines. And the switch is dependent on the initial treatment that the patient had. In terms of the 3rd line ART flow, the first stage includes lab testing, a clinical decision by a team of experts, then 3rd line implementation. I know I did mention that we have a very small percentage of our patients on 3rd line treatment, but moving forward, we are going to get an increasing number of children and adolescents switching to 3rd line therapy. So the time is now, and the time is ripe for us to optimize therapy for our patients, because we know that adolescents and children are going to be the population that's going to be longest on antiretroviral therapy. So it's important for us to have targeted interventions, including optimizing their antiretroviral therapy right from the 1st line treatment to their 2nd line treatment, and providing antiretroviral therapy even during this COVID-19 pandemic. I want to acknowledge my parent department, but also to sincerely acknowledge the Baylor Uganda team, IDI, as well as adolescents and caregivers, and the organizers of the interest meeting of 2021. I'd like to sincerely welcome all of you to the interest meeting in 2022, which is going to be held here in Kampala, Uganda. Thank you very much.